The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to another episode of the Success in Practice podcast. Today, I'm joined by Azharuddin Fazalbhoy. Azharuddin is a trained and registered osteopath with a special interest in non-surgical management of scoliosis. He holds a Bachelor of Applied Science in Osteopathic Medicine, a Master's in Osteopathic Medicine, and a PhD in Medicine conferred by the Faculty of Medicine at the University of New South Wales. He has been treating adult and pediatric scoliosis amongst other musculoskeletal conditions using bracing and exercise. He is certified in both the scientific exercise approach to scoliosis, a scoliosis-specific rehabilitation program, and is a certified Scoli brace provider. He is also the head of RMIT's Osteopathy program, and it is in this regard that we have a very special interest in talking to him today on the podcast. But I do want to explore the backstory and also his particular experience in osteopathy. But without any further ado, welcome to the podcast. Thanks for being on the podcast, mate.
Yeah, thank you very much for having me, and thank you very much for the invite.
That's okay. I really appreciate you doing this. Like with all the educators that I've had here, it's always good to see that people are open and honest and want to have a chat. And I'm happy to answer the questions that some of the listeners want to ask and want to hear about, because I think you'd agree that as a profession we do all have a vested interest in osteopathic education and the quality of graduates that are coming out of both universities. I've had a chat to Gary Fryer previously on a previous episode. You can all catch that. And today, Az has kindly donated his time to have a chat to me. And so without any further ado, mate, I want to ask you a little bit about your backstory. And I guess people like to know this. I always get feedback on it. Tell us about you growing up. Tell us about your childhood, where you went to school, what got you kind of interested in osteopathy, if that was your first interest. Tell us a bit more about you.
Yeah, so I'm actually a migrant. I came to Australia at the age of 13. I have an Indian heritage. My parents were Indian, and my parents were born in Bombay, or what used to be known as Bombay, now poorly named as Mumbai. And I was born overseas, and when I came to Australia, it was the late 90s. And as most migrants that come to our beautiful lands, they tend to, gather together in communities that feel familiar to them. Obviously, my parents were picking up from a completely different country and relocating themselves to Australia. So, it's not uncommon. In particular, Sydney, I've actually noticed this a lot more, that, migrant communities come together quite strongly. And at that point in time, there was a very growing community, particularly subcontinental community, out in the western suburbs of Sydney. And so, when we first arrived, that's where we were. And I spent a lot of my childhood. I like to say that I spent a lot of my childhood in Sydney, because I feel that that's where I grew up. Prior to that, prior to the age of 13, I think I was pretty sheltered. And, my parents were, not quite helicopter parents, but certainly there was, restrictions on what was possible and what we could do and so forth. And coming to Sydney, I feel like I developed the most there, and I feel very strongly that is still to this day, even though I reside in Melbourne now, still is my home, still my favorite city, still somewhere I'd love to be. But life has taken us to Melbourne for the moment. So
Where did you grow up, Az?
So look, when we first arrived in Melbourne, in Sydney, we moved around a lot. we started off, and pretty much every suburb we lived in was pretty much an award-winning suburb.
Right.
And I'm using air quotes for our listeners on the podcast. And so when we first arrived, we spent a little bit of time in Mount Druitt, because
Right.
Mount Druitt again has a thriving subcontinental community at the moment.
Yeah. Yep.
We were there for a few months, and then my mother, who was a school teacher, she ended up getting a job in Condell Park,
Mm-hmm.
and so we moved to Greenacre.
Mm-hmm.
And this was at the late 90s, early 2000s, where all you know, the street pharmacies were basically thriving.
Mm-hmm.
Lots of drug dealers,
Yep.
Tilapia Street, Punch Bowl, all of
Yep.
those,
Yep. Yep.
fun things
Yep.
that were happening in Sydney during that time. We spent a few years there. I did my high school at Strathfield South High
Mm-hmm.
School, and then once I finished up my HSC, my mum relocated again, got another job out towards Liverpool, so we moved to
Mm-hmm.
another award-winning suburb. And then after a few years there, we spent our last 10 years in Padstow, Alfords Point kind of area. So again, back to that Bankstown type of area.
Geez, mate. Last time I looked, Greenacre, I think an average home in Greenacre was $2 million.
Yes.
An average home now in Liverpool is over $1 million. An average home in Orford's Point, or is that what you said, Orford's
Yes,
Point,
correct. Yep.
is over $2 million,
Absolutely.
and Mount Druitt is quite a beacon of just it's a place now that's stopped, doesn't have the reputation that it used to have. So it's
100%. I mean, when we
you
first
know
arrived, houses were going for, 100,000 to
yeah
140,000. You could pick up a very nice three-bedroom villa.
mm,
And yeah, I mean, St. Mary's. I mean,
yeah
that place was, was rough. It wasn't a pretty place to be. But
no.
it's there's millionaires row there now. So
Yeah, but
yeah,
it builds a lot of resilience too, like growing up in
correct.
those areas. It's
Absolutely.
I think especially as an immigrant, you need some of that. You need to come and get your roll your sleeves up and get in and get a little bit dirty with the population because
Indeed, and look, there's a natural affinity because as migrants, like I say, people we're already, my parents, they're already picking up from what they
mm,
know to be, comfortable to them, and coming to a completely foreign land.
mm,
Naturally, you're going to, sort of congregate with
mm,
others that are familiar to you, and then there's a need for services, so mosques and churches
mm,
and food and shops. You can't. Now there are Coles and Woolies that have very large Indian spice sections. But that's now. I mean, 20 odd years
mm,
ago, it wouldn't something you would be able to see. So, naturally, migrants do come together to form communities, and
mm.
therefore, and that was
Yeah,
a big
not a
part of
bad
my
thing. I
growth.
think the second generation tends to kind of carry that on and probably blend in a little bit. I don't want to use the word better, but just probably a little bit neater in
Yeah,
terms of
absolutely,
how they feel about themselves within the particular community.
no doubt. Yeah,
And
absolutely.
that's part of the Australian ethos. I think it's like a trial by fire. Like you come here as an immigrant, you get really run through your paces, and if your kids grow up and they're okay, you know, they'll
Yeah,
be they'll
absolutely,
be right. Let
no
me
doubt.
tell let me ask you. So you attended high school at Strathfield South. Did you complete your HSC there?
I did complete my HSC there. And the group of friends that I had, although they were, I really had a really good time with them,
Mm,
but the focus of it wasn't on studies. Unfortunately, I wasn't
mm,
interested. I had become very disinterested in studying and so forth.
mm.
And we were probably more interested in just hanging out and being lads. Where with our souped up cars and
Yeah.
driving around the streets, that culture that was there around back in that time. And yeah, by the time it came to doing my HSC, I was very fortunate to be able to get into university. I was the only person from the group of my friends of about 20 boys that got into university. But once I had got into university at that point in time, it really did kind of impact me because I started to become mature and grow up and understood that the sacrifice that my parents had made by sort of picking up from everything that they knew to come to a foreign land. Obviously, we've all significantly benefited from that, but
Mm.
ultimately that kind of message came home to roost, and I haven't looked back since. So
Yeah, I think you're a bit blind to it when you're maybe 12, 13, 14, 15, 16. Yeah, it's not really until you have to maybe earn your own way that you finally
mm,
realize that there's bigger things that have come before you that you need to live up to.
no doubt, yeah.
And there's usually a good sense there, especially if your parents have kind of given you some good values to live by. You tend to kind of pick that up and run with it. You left high school and went straight into your osteopathy degree over at University of Western Sydney.
No, so I mean, I wasn't quite sure, as the typical 17, 18-year-old, not quite sure know what to do. I used to play a lot of sport. I used to play cricket. I used to play soccer,
Hmm.
and so I knew that I was interested in that physical human health aspect of it. I had gone through a process of elimination. I didn't want to do something that was engineering. I didn't want to do anything that was related to numbers. So I had gone through a bit of a process of elimination, and I knew that I wanted to be in the science, biology, health space. At that point in time, also myself and my I've got an elder brother. We had um, fallen in love with Formula One and MotoGP, and become really big motorsports fans. And At that point in time, the driver of the day was Michael Schumacher, and
Right.
his physiotherapist was actually an Indian guy by the name Balbir Singh. And again, as a youngster, you kind of look for these role models. You look at people,
Mm.
you look at sports stars, and when I got into university, I'd got into UWS doing a basic science degree, and within my first semester, very quickly, I had kind of realized that I wanted to move towards something that was more, health related, clinically focused on sort of patient care. And so I naturally had arrived at sort of physiotherapy. Being at UWS, it didn't have a physiotherapy program at that point in time. I didn't want to waste time, and so what I had done was, pick up courses or subjects that I could have potentially spent, completing at UWS, with the intent to use as recognition of prior learning, applying for another health program or physiotherapy program. As I started to align those subjects in my second semester, I actually started to interact with osteopathy students and podiatry students, and I started becoming, sort of friends with a person who was sitting next to me once in a lecture theatre. She's an osteopath, and she described it to me and what it was, and it sounded very interesting. And I was like, okay, well, this is something very similar to what I'm hoping to do and get into. And then later on in that semester, I got invited by that same student to come along to a demonstration that was being done by an external speaker, who I have since then now discovered that it was an English osteopath who was visiting from the
Hmm.
PSO, I believe it was. She had sort of got one of the students up and was doing, as I said, right, like I know now, was a very simple 10-step screen. But
Hmm.
just was watching her kind of do that methodically, observing the body, observing movement, observing motion, and then coming to conclusions about restrictions and movement and deficits. Like, I just found it really fascinating. And I recall that after that demonstration, I was sold. I was like, yes, this is definitely something that I want to do.
Hmm.
And so the following year, I was still obviously still at UWS and applied directly, and I got in. I got offered to do osteopathy, and that's when my journey began in osteopathy.
What year was that as?
So science was 2003,
Hmm.
osteopathy 2004. I started, but because I had already done a couple of units or courses in the second semester of 2003, I was straddling year one and year two of the program. So there were a couple of courses that I did were with the year two students who were in 2004, and then some with the 2000 the year ones.
Hmm.
So that was around that time, 2003, 2004.
Right. And the student that you spoke to that kind of sparked your interest in osteopathy, was she somebody who was already in the course that was ahead of you that had already done it? Could
Yeah,
we
so
have?
she was in her first year of the course as well.
Right.
It was in osteopathy already, and she was in her first year of the course. And
Okay.
naturally, there are some common courses that you do, like anatomy and physiology. And, it was
Right.
one of those courses. So there were podiatry students in there were occupational therapy
Mm.
students in there were osteopathy students in there. And it just so happened, sort of fortuitously, that I sat next to this individual and started cracking
Do we have a
conversation.
name? Can we give her a shout out? Can we thank her for?
Sure. I mean, she's probably going to come to a surprise to her because I've never disclosed this, but Melissa Rice. She was
Melissa
very,
Rice?
very
Right.
lovely. Very, very
Right.
lovely individual, and still practicing as an osteopath
Well,
at
shout out to
she
Melissa if you're listening.
yes. She
We've
was
got you to
really lovely.
thank. We've got you to thank for Az's journey into osteopathy. And who was the BSO speaker that you were
It was
watching?
Caroline Stone, if I'm not
Right,
mistaken. Yeah,
Caroline
yeah, it was
Stone.
Caroline
Yes.
Stone. Yeah, she had come out to do some work, and yeah, very, very fascinating
Yeah,
at that
she
point in
came
time.
out a few times. I remember her coming out. I think the first time she came out, we were still we got we were very grateful to Caroline for coming out and showing us a lot of things to do with the pelvis and you know, her take on somatic dysfunction and movement. But yeah, a
Mm,
very competent osteopath who's got a lot, still has a lot to offer, osteopathy.
yeah,
And I'll circle back and speak to you a bit about Caroline and other people similar to Caroline in a minute, but I want you to continue your story. So you got into osteopathy. You arrived on the first day of the first, you know, the first week of actual osteopathy, because back then it was literally the first class would have been osteopathy class.
yeah, absolutely.
And
Yeah.
who was that? Who was your educator there, and what was your feeling like in that first week?
I mean, look, there was a lot of, excitement and elation, right? I mean, I'd really kind of, it's something that I wanted to do, learn more about. So I was quite excited about getting into the program. I don't have a very vivid memory of semester one and the osteopathy practical class, but I do recall that one of the first lecturers that I interacted with was actually I think someone you've had on the program, Nick Lucas.
Right.
And he took one of our first semester courses, and I just recall the way he presented, the way he came across, his ideas, they were very, very, inspiring, and he continued to be a very inspirational kind of figure throughout the
Mm,
program, particularly for me. I know that he was, kind of viewed in other ways for other students, and they're entitled to their opinion. But I can certainly say for myself, very, very inspirational individual, and that's what I recall very, very vividly. I also recall individuals like Raymond Blaish at that
hmm.
point in time, and then Peter Green, who had also done some work with us in first semester.
Did you
Sorry, in
find
second
that?
semester, first year.
Did you find that inspiration was important as a kind of a first year? I mean, we hear the stats all the time that 60% of students, you know, drop out, you know, in their first year of university. I remember going there and people saying, yeah, look to your left, look to your right. Usually, the person on your left might be there, the person on your right is probably not going to be there.
Mhm.
And so, do you think that that's important to have that inspiration in that first spark of osteopathy to kind of give you that motivation to kind of, you know, get your head down, get your bum up, and do the hard work? Do you
Yeah,
think
I
that's
think so.
important?
I think so. I mean, obviously, we our osteopathy programs at the moment are between 4.5 to 5 years. 5 years is
Mm,
a long time to dedicate to anything, and
mm,
therefore, you always come back to when you've got, big journeys
mm,
and something that you need to achieve. That initial inspiration is always important and critical to reflect upon and go back
mm,
to as to why you're doing something, and that goes across the board in life. And so, yeah, I think that those early influences, I do believe that they're absolutely critical, and really, really important. So when you've got someone who, was very big picture, was able to present an idea of osteopathy in a particular way, in a particular format, I really resonated with that. And, to this day, I have very, very fond memories. Like I say, he was very inspirational throughout my journey. And sort of was again the catalyst to me
mm.
going into academia and getting into doing a PhD and all of those other things. So
Yeah.
very, very, very huge influence.
Fantastic. Okay, so you continued on with osteopathy, finished your undergraduate, went to the masters. Obviously, that's where the clinical setting comes into it. How did you find that? How did you find the clinical setting, getting into clinic? Had you had any hands-on experience? Had you done lots of observation? What was your take on the clinical setting at UWS at the time, and how did you feel about it?
So look, I had actually taken significant advantage of observing people, and I had really gone out of my way to make sure that I get as much exposure as I possibly could. I had never been to an osteopath before. I didn't know what they do, particularly other than that demonstration with Caroline Stone. Even though I had played sports, injuries weren't really a significant, kind of issue for me. So I mean, I had gone out of my way to really observe as many people as I possibly could. And I looked across the spectrum, all the way from people who were doing biodynamics and, cranial type of, treatments, all the way to the individuals who just basically rubbed and cracked. And I started that in second year. And by
Hmm.
the time I kind of had got to third year and fourth year, I had probably watched a lot of people. And I came to the conclusion that, at the end of the day, that, there's an individual and a personal touch to it. In the sense that patients start to appreciate you as an individual and what you bring to them and how you benefit their health journey, and ultimately, what you do and how you do it probably matters little. You would, if you are helping individuals, you're able to still develop a following and develop a patient base.
Mm.
Um, when I got into the sort of the clinical end of the program, I mean, I unfortunately I did have quite a kind of Jekyll and Hyde experience. There were some very very positive experiences, some very again motivating individuals, people who helped, people who were happy to help, provide advice, provide guidance. But at the same time, unfortunately, I did experience quite a lot of the negative stuff as well. I'm never quick to kind of jump to the racist card, but I can't help but feel there were definitely some times where I did experience that, where I did feel that. And there were direct comments that were made to me, sometimes in front of patients as I was observing people, that left me with a very, very sour taste in my mouth about certain individuals.
Was this in the student clinic or in private
No, it was
observation?
externally. It was
Right.
externally as I was observing people, and I remember once I was in fourth year and I had gone to see someone who was a very large mentor of students, and a lot of my friends had were either working with this individual or had gone to observe that individual, and
Hmm.
I also jumped on that bandwagon. And that person just looked at me like literally I stuck out my hand the first 90 seconds in the person's practice, stuck out my hand. Hi, my name is Azharuddin. And after shaking my hand, 6 seconds later said, "You're never going to be a true healer." And I'm like, okay, this is interesting. I'm
Okay.
I'm a fourth year student. I'm literally, kind of about to graduate in the next 24 to 18 to 24 months. It was a very bitter pill to swallow at that point in time. And I remember going back to they were the ones who were encouraging in terms of our clinicians at the and clinical supervisors at the university. And I remember having a conversation with one of them, and she really picked me up and kind of give that sort of help that I needed at that
Mm.
point in time. But I got to see two sides. One that everyone was helpful, very very positive, very passionate about osteopathy. But sadly, I did experience the other side where people were very very condescending, very very damaging, deliberately I felt were not sharing things because
Right.
I don't have a perceived threat. It was very clicky at certain stages, certain tutors, certain people, certain individuals gravitating towards groups.
Mm.
So I did unfortunately get to see that very, very early on, which kind of now it certainly influences the way I work with students and the way I deal with
Right.
students and how I approach my teaching philosophies.
Let me focus on the positives because I think to give fire to the negative is probably not a good thing. Were there any are there any people that you can mention that were particularly kind and particularly not just kind, but you were kind of even impressed with the way that they did things that you maybe look back on and go, yeah, this was a really good experience for me to watch this particular practitioner. Is there anyone that come to mind that you've I mean, I know for me, my particular journey, there are always people that come to my mind that they always kind of just pushed you along and gave you really good mentorship. Not even just by them saying, but just by being themselves. Is there anyone that really stuck out for you that you found to you look back on and go, I'm glad I watched them practice?
Yeah, I mean, look, I think that in terms of the clinical tutors themselves were probably, most
Mm,
significantly helpful. But, they range from very, very experienced to, those who are recent graduates. Suzanne McCleary was definitely one
hmm.
of those that has, significantly helped me through that journey, incredibly supportive.
Yeah,
Um,
she cannot not be lovely. Like she.
Yeah, absolutely, absolutely. There was another practitioner who was a very recent graduate, which I'm ashamed to say his last name escapes me, but Bo,
Right.
who used to work in Thirroul at that point in
Yes,
time
I know,
on the
Bo.
southern
I
coast.
know, Bo.
Yeah.
Yeah.
And then the other person was Karen Manane. She was
Yes.
also very, very helpful. I mean, I
Karen's
think.
down in Sutherland at the moment here in Sydney.
Correct, yeah.
Yeah.
And so, just in terms of, I think I gelled with her very significantly in terms of the wavelength.
Mm,
She was able to kind of almost, quench that intellectual thirst that I had developed, and the uncertainty. I think, obviously, sometimes I was given answers of, oh, just go with the flow and, fake it till you make
mm,
it and all those other things, which, there's a time and a place for that. But as you start to kind of, when you have those uncertainties as a young practitioner, they can be very, very unsettling, and to work with uncertainty, it takes a little bit of time and it takes a little bit of,
mm.
effort to be able to kind of work with it, understand it, and then become comfortable with it.
Yeah.
And so I think on an intellectual level, she really just met me there and was able to answer those questions and to be able to guide me on that. And then also brought along, the other aspects of it, the art of it, the art of osteopathy quite nicely. So, all of those were incredibly helpful.
Yeah, great. No, you definitely need, I think, good, strong guidelines and boundaries as a student. Even as a young practitioner, I think having some, things that you could use in practice that at least create a framework. Now, they could be not totally correct all the time, but at least they give you a framework to work with. And then when
Yeah,
you realize they're not correct, you can start to understand why. But if you don't have the framework to start with, you're just swimming in an ocean
no
without
doubt.
really any direction. But
Yeah,
I'm
yeah,
glad you brought
absolutely.
that up because I tend to see it the same way. All right, so you completed your osteopathy studies. You then obviously had to find a job. And I think jobs at that particular time weren't that hard to find in Sydney. There were lots of practitioners around looking. Um, where'd you go? Where'd you work? And what was the mindset at the time? Was it just, hey, let me just get some hands on people, get some experience, put my head down for the next couple of years? Tell us about that.
Yeah, so prior to the other thing that was quite dancing in my mind at that point in time was the research aspect of it. So in our fourth year or the first year of the master, we had to do a research project, and that kind of it was straddled over 2 semesters. So there was fourth year, second semester, and first semester, fifth year, where we had to do this research project. And I remember at that point in time, picking a topic there was something along the lines of surveying GPs or doctors to just be able to get their sort of ideas about what they and their perceptions of osteopathy. And I recall at that point in time, sort of approaching Nick, who was the coordinator for that unit. And I said to him that, look, you've been inspiring us for such a long time to be able to do research and do develop evidence and so forth. All of these conversations that we've had. Yet when it comes to actually doing projects that have impact, we seem to be finding ourselves doing these other projects. And he took that conversation quite seriously. And a few days later, he came back with an opportunity to do a research project with a professor at the medical school, which had just commenced at UWS. So in 2004, I think it was, they had the UWS medical school had just started, and Nick knew someone who was the chair of physiology. His name is Professor Vaughan Macefield, and there was an opportunity to do a research project with him, which I jumped at. And there were a couple of other students, three other students that were in my cohort that were. That I partnered up with, and we did this project together. And so this particular project that we did looked at referral pain patterns. in human subjects. And what we were doing was injecting people with hypertonic saline, which 7% hypertonic saline, which causes this hyperdepolarization of C fibers within the muscles and creates the sensation of a deep, dull ache, very similar to what you would experience with DOMS. And we were asking participants to be able to draw on a map of a leg exactly. So we used the tibialis anterior muscle in this experiment, and we were asking them to draw exactly where they felt the pain and where they felt the experience. And we repeated this test over 5 weeks. And what we noticed is that, generally speaking, in the first instance, when we were injecting them with this hypertonic saline solution, and which, by the way, it only lasts for about 10 minutes. So it peaks at 1 minute. It was half a mil. It peaks at 1 minute, the pain, and usually people were rating it about a 7, 8, 9 out of 10. So quite intense pain at 1 minute. And then by 10 minutes, completely disappeared. And obviously, saline is naturally occurring in the body, so it absorbs it. And we repeated the same experiment over 5 weeks. And gradually, what we noticed is that by the time it got to week 3, week 4, the participants were actually showing with this study, the psychophysics study, that they were experiencing pain which was proximal to the stimulus site. Whereas in week 1, in the first exposure, it was always distal to the stimulus site. So I was really fascinated by this, and I really wanted to do kind of more. And so as I got to the end of 5th year, I hadn't lined up a job yet. I wanted to take a little bit of time off, a couple of months off, and I knew we weren't going to be registered until, sort of February, March, maybe even April the following year. So I actually approached Vaughan and I said to him that, look, is there a possibility I could stay on during the summer and do some more research work? And he was the one who dropped the idea of doing a PhD. And I was like, oh, okay, this is interesting. I've never heard of this before. And so I investigated that. I spoke to a bunch of people, and there were a couple of academics along the way that I had spoken to. And they all said to me that, look, Az, if you're going to do this, do it sooner rather than later. Before life gets busy and you have responsibilities of mortgage, family, kids, etc., you're better off doing it sooner rather than later. And so that that idea had been implanted in my mind, and I kind of got to the end of 5th year, finishing up with the master of osteopathy, and I said to myself that, you know what, I was tired of studying at that point in time. So I said that, look, I'll go out and I'll work for a little bit, but I always had intentions of coming back. I worked full time for 12 months, and at that point in time, I had started at a practice in Dural, which was a very, very long way away from Alfred's Point and Padstow, but I did that every single day. And then I had picked up another practice in Hornsby. So I was traveling a lot. And then by the end of this was 2009. And then towards the end of 2009, I got an opportunity to work with another practitioner, Dean Zekas, in Punchbowl. So I
Mm.
was sort of spread across 3 different locations. And then the summer of 2009, beginning of 2010, I thought to myself, you know what, I think I'm going to follow this opportunity, and now's the opportunity to be able to do it if I want to. So I started my PhD in 2010, and I had to drop back down to only one practice. So I decided to stay on in Punchbowl because it was very, very close to my residence at that point in time, and I was doing my PhD full time at the University of New South Wales. I had actually told Vaughan that I was absolutely sick to death of Campbelltown campus and the view of it. I didn't want to see it ever again. And so one of the conditions that I put on, kind of, becoming him being supervising my PhD and my doctoral studies, was that I would enroll through UNSW, and I was based at Neuroscience Research Australia,
Mm.
is where I did my PhD.
Yeah, as you come off that M5, mate, you get onto that Narellan Road and you look down into the valley. You never, I think nobody ever forgets that. You kind of
Absolutely,
just look, it's just a valley and there's a university spread out in the valley.
absolutely. Yeah,
And the
yeah.
top of the valley was actually where the osteopathy clinic and all the rooms there was kind of at the top. You could see that top car park.
Correct.
I
Yeah.
think that's burnt into everybody's brain who went there, just that
Oh,
campus, the way it
100%.
was. Yeah, it's
And especially coming out after our clinic shift at 6 o'clock in the evening, and it was
mm,
absolutely dead set quiet. There was no
yeah,
one there. It was very, very sketchy looking. Even the security guards were completely disinterested in what happened. So
yeah.
yeah, I was absolutely sick to death of it.
I
So
don't know who was trying to break in.
yeah, that's right. That's
I
right.
don't know who was trying to break in. But anyway, all right. So you continued working with Dean in Punchbowl. You continued your PhD, but obviously not at Campbelltown. You're away from Campbelltown. You completed that, and then what happened to you? I'm really interested in more your practice side of things. I mean, the research will kind of speak for itself. You got that published, correct?
Yeah, yeah. I managed to get I think about 4 or 5 publications out of my PhD.
Good.
So that was sufficient.
Okay.
Um, but look, I mean, in terms of practice side, I was fortunate enough to sort of work in that area in Punchbowl. I mean, Dean
Hmm.
was a very, very, good mentor. He was very, very experienced, but he spoke a language that was rather foreign.
Hmm.
It wasn't something that we were accustomed to. And so the other person who I have to
Tell me
significantly,
about that. Just extrapolate on that for me. Like, are you talking
I mean,
about
in
the more the I guess the type of language in terms of somatic dysfunction, lesions and positions and restrictions and things like that? Is that what you were?
I mean, look,
Is
we had sort of been exposed to that language, so it was familiar to me. But in terms of just patient management and, sort of
right,
the things of utilization, right? The idea of, body energies and, all of those
right,
other things
right.
and those concepts. Obviously, I think he had a very, very good anatomically kind of, based approach.
Hmm.
He was, direct and indirect, had a good
Hmm.
mixture of both, and his approach towards things, I think, was really, really, beneficial to be able to kind of learn from. But
Hmm.
again, it was just the idea of how your body heals and how it works and what are the things that we're doing to be able to help along its way. I think there was some language that I kind of struggle with. But
Okay.
fortunately, I had another person who had graduated from UWS just a few years ahead of me, Themos Goulas.
Right.
And I would often, our clinic was kind of U-shaped, the
Hmm.
corridor, and as soon as you walk in through the front door, you're at reception, and the first 2 rooms were utilized by Dean, and then you would kind of walk around the other side of the corridor. There was a kitchen in the middle, and then that was my room. And then Themos used to use 2 rooms at the other end. So there were times where I'd literally have a conversation with Dean, and he would, sort of flood me with all of this information, which I wasn't prepared to kind of digest. And then I'd literally walk around to Themos and
Hmm.
like, hey man, what is he talking about? And he said, oh, do you remember this concept and think about that concept? So I really significantly benefited from having, someone who was incredibly highly experienced, 20 plus years, but then someone who was, sort of around the 5 to 7 year mark, who was able to kind of really help me, bring everything down to a level and a language that I could understand and work with.
Okay.
I continued working in practice. I was doing my full PhD full time. So Monday to Thursday was PhD, and then Friday and Saturday was osteo day. And so yeah, I kind of kept that going as far as I was a PhD student. And then I started to develop an interest in scoliosis management. And
How many years did you spend with Dean?
I started in late 2009. I finished up in 2014 when I left Sydney.
Okay.
So a good six years.
Right. And for most of those, you were working, say, 2 or 3 days a week?
I was only working 2 days a week. Yeah, so I
Right.
was literally working Friday, Saturday,
Yeah.
hands-on manual therapy.
And what was your
Very, very.
volume like? What was your volume like, As? Like, what were you seeing? How many patients were you seeing? Was that something that you enjoyed in terms of the patient load?
Look, I definitely did enjoy it. I mean, it was quite substantial. I mean, only over a day and a half, I'd be able to see somewhere between 30 to 35 patients. So
Hmm.
it was quite high volume from that perspective. There was a significant interest in, chronic pain and, long-term injury management. I had sort of seen lots of workers' comp, MVAA patients, or for Victorian kind of listeners, TAC equivalent. So I had started to do a lot of that work as well. Um, and then because my sort of PhD had taught me to write really, really well, I used to do work cover reports and do all those other things as well, which helped substantially. So yeah, I think I was getting a decent volume for the amount of time that I was there for,
Okay.
and it helped me immensely to develop my skills.
And also, I mean, it's good that you don't get paid a lot to do a PhD, so it's good to have a bit of an income that
Indeed,
supports you as well. Yeah.
yeah, yeah,
Okay.
absolutely.
So then you left and you started getting to scoliosis there. Then you left in 2015 and went to Melbourne.
Yeah, correct. So, I mean, in 2014, I had finished my PhD, and I knew that I wanted to continue on some sort of research. I had kind of decided that going into full-time practice wasn't going to necessarily be what I was interested in. Again, I
Hmm.
had developed this special interest in scoliosis management, and so I had a couple of options. Most people who want to stay in research, they either continue to work as postdoctoral research fellows and then get research fellowships from grant schemes, which are very, very competitive, or they get an academic position. And in 2014, I had finished my PhD. I was doing a postdoc at the University of Sydney, and my wife was pregnant with our first child. And I had spoken to Vaughan at that point in time and said, look, what are the opportunities going from forward? And he said, look, as I can probably support you till mid 2016, but beyond that, I don't know where the funding is going to be. So there was kind of like this point where I could have, sort of lost my research job, and I would have to, think about full-time practice. But I always also knew that I really wanted to give back to the profession somehow, somewhere, and at some point in time. And I recall, my wife had sent me an ad that RMIT were looking for lecturers. And so I decided that, here's my opportunity here and now to be able to give back to the profession and come in as an academic, which, as far as I knew at that point in time, were only a handful of individuals. So yeah, I applied for that job in 2014, got granted the job as a lecturer, and I moved to Melbourne at the beginning of 2015 to take on the role at RMIT.
Right. So when they advertise for a job as a lecturer, do they just advertise for a job as a lecturer, or do they look for a specific skill set for what you'll be teaching?
I mean, look at that point in time. Obviously, it was in the role in the osteopathy department. As a lecturer, they were significantly looking for someone who had research experience, someone who had a PhD, ideally. There was no particular kind of subclinical
Right.
interest or anything of that nature. It was really just trying to get academics into the
Okay.
department.
So it's not like they were getting you to say, "Hey, as come over, we need you to teach, technique, or we need you to teach X, Y, Z." You were being hired as a member of the faculty as an osteopath, and then they would decide where you would be best used. Would that be
That's
correct?
correct. Yeah, that's correct.
Right.
Yeah, yeah.
Okay. So you packed your bags, went to Melbourne in 2015. At that point, was there anything in terms of private practice there? Had you started to investigate jobs there as well, so you can kind of do what you did in Melbourne, but what you did in Sydney and do that in Melbourne? Was that
Yeah,
what you
so
were?
late 2014, as I say, I mean, well, actually earlier than that, 2013, I had started to get into scoliosis management. I had a couple of patients that I saw in osteopathy private practice, and unfortunately, both of them progressed. They were both adolescent girls,
Mm,
13 or 14 years old. Their scoliosis progressed, and both of them ended up in surgery. And I was devastated by that experience because here I am. I thought that osteopathy treatment would be able to help in that scenario. Some sort of lateral bending, MET, some sort of management of that nature. Because what we were taught was scoliosis is a cosmetic issue. Don't worry about it. There was no other education around that. And so I followed what I had learned, but very, very quickly had discovered that unfortunately that doesn't hold up. And so in 2013, I was part of a journal club that I used to attend. And the founder and CEO of Scolicare, Jeb McAveeney, who's a chiropractor, he presented at that journal club. And it was literally fortuitously, again, literally a couple of months after my experience with these two patients, and what he presented about bracing and exercise and scoliosis specific exercise really, really got me going in terms of wanting more. So I actually went overseas to do some training, and I really wanted to start to develop my, sort of clinical skills in that area. And in 2014, when I left Sydney and moved to Melbourne, I had taken on the Scolicare clinic here in Melbourne. So I was working clinical part time, and then I was working as a lecturer at the university part time.
Yeah.
Um, it was a very kind of interesting time at RMIT back then in 2015. There was a huge shuffle in staff. I'm not privy to exactly what the circumstances were, but as far as I recall, and my information could be inaccurate, but there were 4 or 5 staff members. One had just left the year before, which was in 2014. One had left, in February 2015, literally a month after I started, and one departed in July 2015 after I started. And
All
the only
right.
person left was Ray Myers, bless him.
Mm,
He had been the head of the program for 16 years and
mm,
absolutely exhausted, and wanted to step down.
right.
And so I started to get visions of what happened at UWS, because obviously that program shut down. Now,
Mm,
again, I'm not privy to know sort of what happened and the circumstances around that. But knowing what I know about universities now, I have no doubt in my mind that one of the decision-making factors would have certainly been about the academic workforce. And so here
right.
I am picturing, I've picked up my family, I've moved down to Melbourne, I've relocated, I've got a 6-month-old, 7-month-old baby, and here now I'm getting this person who's 16 years head of the program that wants to resign, or someone wants to retire. This
Mm,
could be, an important time for the department. This could be the closure of another program. And so sort of in June, July, I think it was in 2015, I told Ray, I was like, look, is there any opportunities for me to be able to kind of step on board and do something about this? And he organized a meeting with the executive dean at that point in time for the School of Health and Biomedical, well, it was known as the School of Health Sciences at that point in time. And I just boldly said to him that, look, give me an opportunity, I will do it. And I very quickly, in October 2015, going from my first lecturing position, October 2015, I found myself as the head of department, taking over from someone who had been there for 16 years. And basically, I just had to pick up and run from there.
right. All right. Let me take you back a little bit. So you said that there seemed like there was a bit of an exodus of staff from the program around 2015 into 2016. Is there any? Do you know any information about why that might have happened?
No, I don't. No, no,
Right.
unfortunately, I don't. I mean, I can't even tell you whether there were voluntary or involuntary
Right.
departures. But yeah, it was certainly a challenging time for
Mm.
RMIT. Yeah.
And obviously, I mean, Ray. Everybody that I've talked to that had been through RMIT during the Ray Meyer years always say what a privilege and a pleasure it was to go through that university. And just to give you my experience that I've mentioned on this podcast multiple times, and you probably remember this too, as being a UWS graduate. I mean, I was the second cohort to go through the UWS program, and we had some people who were recent graduates from RMIT come down and teach us at UWS. And we used to always be in awe of these super people. Like they were just super practitioners. RMIT had such a great reputation for producing really, really wonderful osteopaths from the get go, like from
Yeah.
graduation. The course was tough, and it just produced really good osteopaths. And you'd probably credit Ray for a lot of that, obviously being head of the program. But for some reason, we were all in awe of of a lot of these graduates who came out. So it was a wonderful program. And from what you're telling me now, it literally went from Ray, who had been there for 16 years, and this is not a criticism of you because it's out of your control. To then go to someone like yourself who had barely had 12 months in of experience in lecturing. Would that be a fair assumption?
Yeah, look, it is a fair assumption. I mean, at the end of the day, as an academic, I had certain other skills that I was bringing to the table.
Yeah,
I was the first PhD in the department, so I certainly
yeah.
came along with my own expertise and my skills. But yeah, look, I mean, in terms of the hands-on stuff,
I mean, like you had
so
to you had to. I mean, Ray had 16 years to kind of understand. It's like when you see a patient, right? Like I always say to people who had been to see other osteopaths, I say, please, give me a bit of time. They've seen you for 5 years. They understand your tissues. They've had time to acclimatize to your condition. Just be patient with me, and I'll get there. And it's the same thing. I mean, it will be the same thing with what you were doing. As much as you're coming with expertise and experience and kind of your own kind of views and skill set, you would have needed time to kind of cut your teeth, understand what's going on, and kind of hit the ground running. It's not an ideal thing, I would say, just looking at it from an outsider. And I mean, this is the first time we've had a conversation, and if I ever, I mean, I'd sit and have a drink with you. I think you're a lovely guy from what I've talked to, you so far. So I'm not criticizing you at all. I just think that it seemed like it's to go from somebody who had run the place for 16 years to you barely coming in with 12 months of experience in the program. That would have been a massive task for you to kind of at least maintain the level of I guess the level of competency and work as to what Ray had going on. Did you find that difficult, As?
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also, in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
yeah, look, I mean, that transition was difficult to begin with, no doubt. And, I was very well supported by Ray. He continued to kind of, feed into, the program and help me kind of work through it, sort of late 2015 all the way to probably halfway through 2016. So, it certainly was, while I make it sound like a rip the band-aid type of action, it was a little bit more of a transition from that perspective. And I really started to fly from sort of mid 2016 onwards. But I mean, fundamentally, this is the difficulty that we have, right? We've got certain individuals who are, absolute giants of our profession, and who are in, roles like this
Mm,
at a university, who are in the academic space, and there's hardly any. Sadly, there's no succession plan. There's
mm,
no ideas about going forward because, unfortunately, and again, I'm saying this very, very respectfully, but we've got a very harsh attitude towards academia and academics in particular. I think academics are certainly, and academia in osteopathy is certainly undervalued. And no wonder we find ourselves in these positions where you have a mass exodus and there are question marks about the program and the viability and all these other things. And then we find ourselves in these positions. So it wasn't ideal by any means. And it was very, very difficult to begin with. But, I felt like I had experienced a certain amount. I was a tutor at UNSW in the medical school. I was a tutor at UWS. So I had some teaching experience, and I had sort of brought along that. I was an osteopath. I'd worked as an osteopath. I had hands-on skills, learning from people who had graduated from the International College of Osteopathy and the Pacific College of Osteopathy and so forth. So, I definitely had my training wheels well and truly on for a period of time. But yeah, it was definitely a transition. I'm not going to underplay it. But we managed. We had to do it. There was no other option. What was the other option?
Yeah, no, definitely. I mean, like I said, it's not through any fault of your own, and it's actually probably a good thing that you stepped up and said, let me do it, because
Yeah.
it didn't. And from an objective point of view, it didn't look like they had a lot of candidates. Like it's not like they had, 7 people to choose from.
Mm.
The fact that you knocked on the door and said, I want to do it, and they gave it to you, that's a good thing, because I think otherwise they would have been in a bit of trouble.
Yeah, I mean,
Um,
look, it's a tough gig. I mean, I don't think Ray Myers you would have intended in his first year of leadership that he was still going to be there 16 years later on.
mm, mm.
So like I say, I think as osteopaths as a profession, we
Mm,
need to really relook. We need to look at this issue. We need to think about it and have a bit more of a strategic kind of approach towards it, about succession planning and thinking about who drives this place forward and these institutions forward.
yeah,
So yeah, it's a tough gig. It's not an easy
yeah.
gig.
I'll come back to that, because I want to ask you about some of the challenges that we face as as a profession. Um, but I want to continue on with discussing scoliosis for a minute with you. Obviously, it's your area of practice and clinical interest, and you've obviously done a lot of research and study in that area. I was surprised when you said that, the way that you were taught, in whether it was in osteopathy or in medicine, was that it's a cosmetic thing, that scoliosis is a cosmetic thing. My experience with it, I mean, we all got taught the structural versus functional kind of model. There's structural scoliosis, functional scoliosis. Very rarely do you ever get the structural without the functional. And I guess the structural stuff is not very easy to unwind. I mean, if you think you're going to do that with some HVLA, some biodynamic, that's very tough, because it's structural, right? It's part of our philosophy that, structure affects function. If there's a wedge in that vertebrae, that's, unless you get in there with a hammer and chisel, which I don't think anybody's going to do, either you need some bracing, you need some surgery, and you'll definitely need some exercise. You figured that out, obviously, with your particular approach. But why do you think that I guess the methodology or the approach that you were taught was quite cosmetic versus what you ended up learning through your own adventures?
I mean, look, I think fundamentally was, the overall clinical management. How do you manage that patient? And at that point in time, I was not, informed. And I'm placing the blame on myself, because I was already a graduate at that point in time. It was my responsibility, but I wasn't informed enough about its progressive nature. I was
Mm,
always, and even coming back to that idea of, a structural versus a functional scoliosis, that in and of itself infers that you've got a structure that's working in a certain way, but that structure gets worse over time. And that was the
mm,
critical message that I missed, unfortunately, or wasn't privy to. And so all of a sudden, I've got this 13-year-old who is, kind of growing, developing. The bones are still taking shape, they're still forming. That structure is deteriorating 24 hours a day, 7 days a week,
yeah,
as
it's
as
very
long as
rapid.
their skeletal maturity is still being achieved. And so, that was the message that I missed. So having
Mm,
them come in for treatment and aligning them and doing all these other things, while, partially and, for a short period of time, maybe helpful, if at all. But it was the overall clinical management. I needed to have reached out to other individuals. I needed to have reached out to other healthcare professionals, and I needed to have reached out to others to make sure that the curve was being managed appropriately, and we weren't just trying to manage it in house with osteopathy.
Okay, so then you obviously did some extra study and some extra research around scoliosis, and I think your particular accreditation is as a Scolly brace provider. Is that correct? You're certified as a Scolly brace provider.
Yeah, correct. So,
Tell us what that means.
So basically, as I mentioned earlier, the CEO of Scolicare, which is an organization here in Australia, has clinics in nearly every major city in Australia. We're an organization that tends to, not only offer patient management, but also lots of education and research into scoliosis. Jeb, who is the CEO, is regarded as a world world expert, I should say, in conservative management. And he had developed this and has the intellectual property for a brace, which utilizes concepts of, kind of adjusting or applying pressure to the curve in a three-dimensional way, and also not only sort of correcting the curve, but also potentially mirror imaging it. So someone who's got a right thoracic curve, not only are we putting pressure or making that curve or spine align itself into the middle with that brace pressure, but we're almost mirror imaging that, and that seems to get some very, very good outcomes. So I started working with Scolicare and started working very, very closely with Jeb at that point in time. As a provider of that technology, I had to go through some training and in-house training. The CAS certification, so scoliosis, scientific exercise approach to scoliosis management, that is an institution in Italy by the name ISICO, and I had to go through some training there on the exercise aspects of it. So, getting all of this additional kind of, tools and learning all of these other additional approaches, which, there are international clinical guidelines for managing idiopathic scoliosis in particular. I had to sort of learn those sorts of approaches and ways, and that's wholeheartedly how I kind of practice at this point in time.
Right. So are there still any hands-on components to what you do as?
So the way Scolicare works is that we co-manage with our practitioners. So, and I think that this is one of the most wonderful things, because we're interested in scoliosis management. We're interested in managing the curve and the patient. And we're better off positioning ourselves in a way that we can co-manage with other healthcare professionals or musculoskeletal therapists. So as the osteopath, as the chiropractor, as I said, mentioned, Jeb is a chiropractor, or the physiotherapist, you can send your patient along to Scolicare and they have, bracing and exercise. But as far as the hands-on manual therapy component, where it's indicated in terms of symptom management or other care, then they go back to their referring therapist. So at the moment, I don't do any hands-on manual therapy. That's not part of my clinical, kind of skill set that I do anymore. I do teach technique at the university, but it's mostly bracing and exercise that we're interested in.
Right. Okay. All right. Well, then let me then ask you more about, and just to clarify, I mean, I've seen some of the polyurethane kind of braces. Is that similar to what you're talking about in terms of the brace, the Scolicare brace?
Yeah, so it's made from a modified polyethylene plastic,
Yep.
and it comes in different densities, so more softer braces for younger ages, more
And
stiffer,
it's
harder braces.
customized. It's
It's custom
customized.
made. Yeah, and,
Custom
and
made.
again,
Yeah.
that's one of the good things that Scolicare does is that it's custom made braces. They're not off the shelf that then, add pads and so forth like that. While there are some other braces on the market that claim to be a little bit more flexible and a little bit more dynamic, in terms of the outcomes, what I've seen over the last decade that I've been doing, bracing and exercise, a rigid brace is far superior and gets some very, very absolutely sensational outcomes.
All right. Let me kind of move on to the I guess the academic aspect of what you do as an osteopath. As you're head of the program at RMIT. You also mentioned earlier that you still teach technique. but you're not actually practicing manually, or you're not using manual hands-on therapy in your current practice. As a from a I guess a principal point of view, do you think that it's best that we have people that are doing this day in, day out, teaching technique, teaching osteopathy, teaching the practical side of osteopathy? I mean, we need to appreciate the academic side that goes along with it as well. But do you see obviously the argument that can be made there for somebody who's doing this day in, day out? And I've had conversations with on this podcast with people like John Pitcher, who's been working for 40 years, and Bruce Duncan, and other very experienced osteopaths who have taught technique at RMIT, and who people have talked very highly about. And so do you think we need to encourage that from an educator, you, being as head of the program? Do you think that that needs to be something that needs to be encouraged in a program, where somebody who's actually doing what they're teaching day in, day out?
I mean, look, there's a two ways that we can answer that. I mean, at the end of the day, I think it's understanding what the program is. We have approximately 500 students across the program. We've got staff members, 6 or 7 at the moment, and due to inherit an eighth individual who are on staff. And then we have a very, very large pool of sessional lecturers and tutors and clinical supervisors. Every single one of us is an osteopath. Every single one of us is registered as an osteopath. And every single one of those has hands-on manual therapy as part of their daily practice. So in the classes that I teach, and it's not only me that's in the classroom. We have very, very large cohorts, and so I'm accompanied by 2 or 3 other demonstrators who do this day in, day out. I don't agree with that. It's something that you have to do on a daily basis, and that's the only way to give you a license to be able to do it. Again, as I said, I've done it. I've been trained in it. I've done it. I've mastered my craft, and now I'm at the point where I'm be able to sort of provide that to students and do it in a way that it's understandable, and in a way that helps them develop that skills. But I'm not the only individual that's there. They then go on further, in addition to getting sort of supervision from practitioners who do it on a daily basis, if you want to use that argument. Then they get supported by individuals who again are practitioners. So all of our clinical supervisors, a significant majority of them, I'd say probably about 98 to 99%, are all sessionals who give up their practices for half a day or a full day, and then they come in and they supervise our students. So, my role is very, very small within all of that. It's osteopaths that are driving a lot of the education. It's osteopaths that are, doing the interactions with the students. I'm a very, very small component in that approach. And what I try to do is obviously think about, again, clinical expertise and clinical thinking and clinical rationale and clinical reasoning. These are all the other things that also come into scope. So I kind of reject this narrative that that we have to be doing it on a daily basis, and if I'm not doing it on a daily basis, somehow I'm compromised. I don't agree with that narrative.
Okay. Um, the feedback that I get from, I guess, when you have a podcast, not that I've been doing this for a long time, but people automatically think that you're some kind of investigative journalist, which I'm not, right? But people reach out to you and they say, they tell you things that they're upset with, or things that they feel like they missed out on. And a lot of people have reached out to me and said, we feel, especially new graduates, they say that there's a disconnect. They find a disconnect between what the skills that they leave university with versus the skills that are required in private practice. And not only are new graduates messaging me with this, I actually had someone today send me an email and say that they are a business owner in Melbourne who are finding that they've had to put so much more time and effort, not into just mentoring, say, the mindset of a practitioner, which I can understand that, but even the skill set and the clinical reasoning and the I guess the osteopathic reasoning of graduates, not just from RMIT, from VU, from SCU. And so there's a bit of a disconnect at the moment between what is being produced versus what is required from the profession. Have you discussed that with anybody, either in the profession? Have you heard that at all? And I guess if you have heard it, do you have any empathy for that position?
So look, I mean, at the end of the day, I think we really have to question mark sometimes where these narratives are coming from. I think very strongly that as experienced practitioners, we tend to forget exactly where along our journey we've learnt our skills. We seem to have this, really, really selective memory of a rosy idea that you finished university with these ready to go skills that were absolutely refined to the nth degree, and you were practice ready. I think that most people that you will find are probably not there, and that's not the case. And I can honestly tell you that those are the same narratives that I remember hearing when I was a university student, and it's probably going to continue going onwards. So I think that at the end of the day, that there are some practitioners that tend to project some of these, kind of ideas onto students, and then therefore students feel like there's a grievance that they're not being taught or they're missing out. I think the reality of the situation is we have to look at the market that they're graduating into. The health market that they're graduating into now is significantly and vastly different into a health market that graduated even 10 years ago. It looks different. The skill set that they need to have is vastly different. I think that the hands-on manual therapy skills that they are getting, and I can show you the curriculum, I'm happy to share that. It's very much reflects pretty exactly what I would have done when I was at UWS. Okay, so 20 years ago, in terms of the hands-on manual therapy, the things that we used to learn, and again, I inherited what's here at RMIT. So everything that has been done, it has continued to happen in that way and in that fashion. But at the end of the day, we also need to raise the students' skills in another direction, because what's demanded of them and what's required of them is something different to something that we didn't have when we were graduating. So I think it's the way I view it is a case of, we know we were always very, very good hands-on manual therapists, but we had lacking skills in other areas. And now what we're having to do with our education, because we can't allow them to graduate with those lacking skills in other areas, we're having to upskill them in other things. And so, from that perspective, there might be a narrative out there from practitioners that, oh, we're not getting what we used to. But the reality is that what we're preparing them for and what we're graduating them towards looks different to what our time was when we were students. The other thing I would say to that is that it is a accreditation requirement that our programs are, receive feedback, ongoing monitoring, as well as implementation of that feedback from an industry advisory committee. So we have a committee of practitioners, all the way ranging from 25 years plus experience all the way to 3 years plus experience, that whole range, that provide feedback on our program. And we're not allowed to amend, change, or change at will unless that committee approves it and unless that committee provides feedback about it. So everything is monitored. It's all osteopaths that are doing this work. Unfortunately, as I say, I do believe that there are some very, very negative narratives that are around about, the skill set of graduates, and I think that sometimes those are perpetuated, and then obviously the student doesn't know any better, and they feel this very, very strongly. And again, it's skills that they will learn with experience. It comes with experience, and this idea that we were all, myself and yourself included, that we were these perfect practitioners when we graduated. I actually don't think that really holds true.
No, I agree with you. And that's not what I was saying. It's not that the idea is that practitioners need to be even close to being perfect. Which there's no such thing. I mean, it's always a process, but just to have a certain level of competency where they can come out into private practice, understand basic concepts like rebooking and what are the physiological parameters around how many treatments a patient needs that has a certain condition. Just to give you one example, things like even just having a particular understanding of osteopathic philosophy and principles and how to apply those to your practice. And those aren't unreasonable requests, I think, from professionals for an osteopath who's graduated to have at least a basic understanding of. And so I guess I don't want to, look, you said that there might be some negative narratives out there. I don't think they're negative narratives, as I think they are people's experience, and there's plenty of positives. Like I hear some positive things about new graduates and what they're doing as well. But we've got some problems with keeping osteopaths in the profession. Those problems have been reflected by the association. They've been reflected by business owners. They've been reflected by, I guess, looking at different models of practice, employee, contractor, and also the expansion of osteopaths into other areas such as aged care and disability services and occupational therapy services and so forth. So
I mean,
osteopaths are having to go into different parts and not just private practice, but some of that has been because they haven't been able to find success there in private practice. And as much as we love the fact that osteopaths are going out to other areas, I think private practice is still the baseline of I guess what an osteopath can expect to do when they graduate. So we're just saying, like, is there any accountability there from the educational institutions, or are we just going to kind of say, well, we're not looking for a graduate now to be at the same level of a graduate 10 years ago because the market's changed. I understand that, but it's more so just actually having a certain level of competency for today's market, right? And understanding certain concepts that can get them through that first couple of years of practice so that they can then go and gain their experience and go, we don't want to lose them. We don't want them having to lose their confidence. And all the experienced practitioners that I talk to say that there's a lack of understanding of osteopathic philosophy and principles that keeps the motivation and the spark there. That spark that you described, about when your first experience in education, that's really important. And we want that to be maintained in their first couple of years. So I guess the question is that, do you think that the educational institutions bear some responsibility in making sure that there's osteopathy in the osteopathy program that is being taught by osteopaths that are practicing osteopathy day in, day out?
yeah, I mean, look, it would be naive to say that it's not multifactorial. It's definitely multifactorial, but I think that there's other, sort of things that are happening, from a societal perspective, from a landscape perspective, that's shifting sands. So, absolutely, everyone, like I said to you earlier, every single person that teaches into our osteo-specific program and our osteo-specific content is a registered osteopath, is a person who works in private practice. They're all osteopaths. There's no one else. So, they are still getting that interaction. They're still getting that information. They're still getting that person who is inspiring, just as I got that inspiration. But again, I come back to the fact that again, it's a different, completely different market. I mean, we published a study in 2003, 2023, I should say, which looked at the views of osteopaths, Australian osteopaths, and stakeholders about the profession. And we found that we interviewed 18 osteopaths and we interviewed six stakeholders, and there were some very, very interesting findings. It was very, very apparent that we split this up, and I can send you this the title later if you would like to, and readers would like to engage with it. It's published in the International Journal of Osteopathic Medicine, and we split it up into positive and negative kind of themes. And in the positive, there was a lot about the profession and what it can do for patients and that help and that etc and those sorts of themes. But the negative themes very, very clearly, unfortunately, from even newer graduates, that they felt that there was poor career sustainability. Most newer graduates from the outset, they were already saying that they wanted to change careers in the future. They were afraid of things like physical burnout. And the other thing that they commented on was the financial instability. So again, you have to look at it from a perspective that, yeah, I mean, like I say, that it'd be naive and incorrect, and completely turning a blind eye to suggest that maybe the institution hasn't got a factor in it. But ultimately, like I said, they're graduating to a different space. I mean, these kids are coming out with, a life that is extremely expensive. They've got, tens of thousands of dollars of student debt that they're incurring. The amount of time that they have to be able to get success and become quickly better at it is very, very challenging. We had the time, we took the time because our life was different at that point in time. The demands were very, very different. We took the time to be able to improve our craft and stick at it. But now the demands are very, very different. And I'll give you another example, right? I mean, if you're a student, I mean, if you were a new graduate and you were told by the practice principal who has you on a what's the word? What's the opposite of a contract? Sorry, my brain
Employee.
is fading. No, I mean, so if you're a sole trader, right? If you're
Right.
working as a sole trader, right,
Hmm.
and you're on that sort of contract, and you're getting your 30% or 40%. The high degree of variability in terms of how many patients that you see, majority of them are still having to hold on to their casual jobs 12 months, 18 months, 24 months into their osteopathy career. Now, the question would be, would you hang on to that and stay the distance and go the distance with that? Or would you think about if a medical device company who's dangling a significant carrot of giving you a phone, giving you a laptop, giving you a car, allowing you to fly to different major cities, be scrubbed into surgery while you tell the surgeon about putting this screw and that pedicle screw and this rod? I mean, as a young 20-year-old, there's definitely going to be a cohort of those that are going to find that far more attractive, far more stable. And, again, at the end of the day, they are taking up these opportunities. As the study that we, sort of published seemed to suggest, it's those things. It's that sustainability. It's the fear of burning out, particularly physical burnout, and the financial instability that's driving these new graduates to turn around and blatantly say, I'm looking at something else into the future.
So, okay, so if there are new challenges out there then that new graduates are facing, I guess then is the educational institution shifting its I guess perspective to make sure that those graduates can meet those challenges?
I mean, look, like I said to you, at the end of the day, I think that we've always had that strong suit, and this is across the board as the osteopathy profession I'm speaking about, not just RMIT. I think we have that strong suit of manual therapy and hands-on therapy. We're very, very good at that. Our practitioners are amazing at doing that, and I'm talking about the profession wide. We have some amazing hands-on manual therapists. We do that very, very well. We run CPD courses. We have lots of things that are happening within the profession that address that and target that and do a very good job of that. But fundamentally, as far as other things are concerned, we need to lift our game a little bit. We need to be able to provide opportunities for transferable skills. And this is the problem. And, it goes to a broader issue that we're experiencing right across society right now is that you have people who are, universities, the way they're training, the way it works, you dedicate 5 years. I mean, 5 years is a long time to dedicate to anything, right? I mean, marriages don't even last 5 years these days. So you spend all your time, 5 years of your life, full-time student. It restricts your earning capacity during those 5 years to be highly trained in one area and one aspect. And when you get to the end of it, potentially you realize, that being in a 3 by 3 room isn't for you, or you're being dangled this carrot that, hey, if you stick at it 18 months, 24 months down the track, you may become good at this. Again, we have to be able to give them other skills and other avenues that they can consider and think about. I was a lead investigator along with Lee Muddle and another very talented young osteopath, Chanel Mastronado. We got a grant. Lee and I got a grant from Osteopathy Australia to write a strategic plan for the profession until 2030. We assembled together a steering committee that was full of osteopathy professionals. The chair of that steering committee was Michael Mulholland himself. We conducted this project over 2 years. And again, one of the things that we all found was that it was really important to think about career diversity. I mean, I personally feel I think it's very tragic that we have osteopaths that are studying for 5 years who are, obviously accumulating student debt, have reduced earning capacity during those 5 years, are putting the rest of their life on hold. They finish at the end of 5 years, and within 18 months, they're out of the profession. That's tragic. We need to really be thinking about how we can skill them up sufficiently so that when they go out there and they've got opportunities at residential aged care facilities, or insurance companies, or rehab providers, or other things, or other avenues, we should be skilling them to be successful in those spaces. Why not? Osteopathy is extremely special. I agree. You agree. Why don't we want to share that around in other spaces that could make us successful, that could see these students succeed, that could see these graduates succeed and spread right across the board? I think everyone's a winner in that scenario.
Well, we do want to do that, and I think at its very heart, osteopathy is about helping people, right? Like medicine's about helping people get out of, I guess, their health problems, and osteopathy is no different to that. And so whether you do that in private practice, whether you do that in an aged care facility, whether you do that, in disability care, it doesn't really matter. Those opportunities are opening up to osteopaths, and largely because of volume. As I think,
Indeed.
the more volume we have of osteopaths out there, the greater awareness there is, and understanding that, hey, osteopaths can do and that wasn't any different in our time. Like, graduating in our time, I felt like I could do everything a physiotherapist could do. I could do everything and I could do that in different settings. And so,
Sorry to cut you off, but I mean, like the widespread recognition is mind blowing. I've got experience now being an osteopath in Sydney, and I've got an experience being an osteopath in Melbourne, and I can honestly tell you the level of awareness of osteopathy and osteopaths in Melbourne is mind blowing. I cannot recall even one scenario in Sydney where I didn't have to explain myself as to what an osteopath is.
so why do you
What do
think
they
that
do?
is? Why do you think that is, As?
I mean, I think again it comes down to the volume. I think there's significantly larger number of practitioners.
That's totally what it
Um,
is. It's
yeah,
it's
and
totally what it is. It has
yeah,
nothing. It is 99% of the reason for that is volume. There's
mm,
literally more osteopaths in Melbourne, and it's great. It's fantastic for the profession down there, and it's opened up a whole bunch of new avenues. And so we want to make sure that obviously we do that in other parts of the country, Sydney, and part of the reason for the volume outbreak is the fact that you've got two universities pumping out students, and we want to make sure that those students obviously get a great education, and any other programs that do open up across the country. We need to make sure that those students get a great education, but we need a volume of students across other parts of Australia. So there's no debate there. I think that the volume has definitely made a big difference. But yeah, I don't think it's any particular change in what education has done in the last 10, 15, 20 years that's made a difference in terms of, I think it's just the volume of patients that have come out. But you're right. I think that there might be an avenue there for educational institutions to maybe inform their graduates a bit better about how they can get into aged care, how they could get into different services and different industries, I guess. And I think the degree should reflect that quite well. My particular concern is that whilst doing that, we don't want to, I guess, forget our roots in practice and helping everyday mums and dads and families improve their lives. I think we need to make sure that we still understand that osteopathy has a place in private practice. And then it seems like there's been a bit of that spark that's lost in the graduates. They come out and they're very quickly dejected. Now, you've said that it's a different marketplace, but every generation has its challenges. And yet somehow we find that this particular generation is needing to go and find that outside of the university, more so. I'm not saying it doesn't exist there. I'm just saying that more so they're needing to find that out in outside of the university setting. Just to give you a bit of context, I've had people on the podcast who have mentioned that lecturers at RMIT have told them that there's no difference between an osteopath and a physio and a chiropractor. We're all heading down the same path of regulation. We're all going to just be musculoskeletal therapists. They've had people tell them that, you know, we're no different than any other allied health practitioner. That seems to be feedback that I get from a couple of ex-students there. And so when I said this to Gary Fryer, he actually was able to go and look at what was happening at VU, and to his credit, made some changes to the I guess the teaching of osteopathy itself, the philosophy and principles and application of the rationale. Do you have you heard any of that feedback? And if you have heard it out there, rather than maybe just saying that it's, you know, negative talk from people who wish things were better, do you think that there's enough of that happening at RMIT that warrants no looking at, or do you think that that could be looked at in terms of making sure that we maintain our identity, we maintain who we are as a I mean, clearly, I'm going to ask you the next question based on that. But do you think that you're doing a great job there at RMIT in terms of teaching osteopathy in terms of not just how we practice, but how we think?
So look, I mean, I think I truly believe, and I think that probably that quote about physiotherapy and other manual therapies sort of converging more than diverging. It's probably something that I've said along the way, but I think that's being misconstrued. Ultimately, we have our sense of uniqueness. As I said earlier, we're hands-on manual therapists. It's still a very, very large feature in our program. The recipe hasn't changed. The recipe hasn't changed. I went through a 5-year program. You went through a 5-year program. RMIT's always been a 5-year program. And in the foreseeable future, we've just been reaccredited. It's a 5-year program. We used to do clinical practice, osteopathy, clinical practice at an internal university clinic supervised by clinical supervisors who are osteopaths in the community that own their own businesses and have their own osteopathy practices or work in large osteopathy practices. The recipe is exactly the same. We haven't innovated, we haven't changed. And even now, our students do go out to a residential aged care facility. We've got our students placed there. We also have our students placed in our RMIT Sports Academy where they see athletes and so forth like that. The recipe hasn't changed. We still do soft tissue in year 1. We still do articulation MET year 2. We still do HVLA year 3, sorry. We still do counter strain. We still do all of these things. So I think that the recipe hasn't changed at all away or moved away from what it has been. I can tell you first-handed because I know the program inside out. I'm integrally involved in every aspect of it. That we still teach the principles, we still teach the philosophies, we still talk about AT still, we still do all of those things. I think maybe, and again, like I will be naive to say that there could be improvements. There certainly could be improvements. I can't help but feel that a proportion of that is also coming back to what you and I were talking about earlier, which is a volume. Now, if you have a group of students, let's just say, for example, we've got 30, 40 students that were graduating. I was part of the largest group that graduated from UWS. We were 60 odd, 57 to be precise. The academics were losing themselves. They were beside themselves. They didn't know what to do with 57. The largest intake that RMIT has had was in 2019. We took in 199 students. I mean, that volume is significantly higher than that's ever been. And so if you see, say, for example, out of a cohort or a graduating cohort of 30, 25, 30, and you have 3 or 4 that don't quite gel and have this misunderstanding and not quite kind of, getting along with the philosophies and the ideas or don't quite have that spark, let's just even on a numbers game increase that eightfold. You already have a group of people who seem to be larger or seem to be a little bit more frequent than infrequent, if you understand what I'm trying to say. So I think that, really, I do believe that it's a range of things that are feeding into that. The health market is different. We have to accept that. The students that we have are different. The way they learn is different. They're not up for coming to on a Saturday. I mean, when I learned HVLA, it was Peter Green that taught us, and was significantly assisted, or was co-assisted by Amanda Hannaford. Bless them both. Very, very lovely people and great osteopaths. But I did a weekend course with Philip Tian and Peter Gibbons, Professor Gibbons and Professor Tian, on a Saturday and a Sunday. I can't even get, like, the idea of sacrificing that time to be able to come in and do extracurricular. That's the lens that we went through. That's how we learned. That's what we did. Learning is very, very different now. It's not what it used to be. And again, like I said to you, I don't think that, this is one point or one thing that's driving all of it. It's multifactorial. All of these things lead to the point that we're at, and lead to these ideas or observations that potentially the graduates are not, kind of inspired as they used to be.
So what you're saying is that if you were to organise somebody to come in on a weekend and say run a workshop for your students, you don't think there would be a great turnout of students?
We literally had an osteopath that came last week on Thursday. Out of a cohort of 500 students, we had 26 attend.
Right.
And no amount of beer and no amount of pizza, no amount of, vegan tuna, whatever it is sufficient.
Yeah.
Life is different. The pressures are different. The kids, what they have to go through these days, it's tough. It's not easy.
I agree with you there. I think there's an element of personal responsibility as well for the person who's becoming educated to actually take it upon themselves. And I remember what you said. We were offered almost every other weekend some presenter that was coming in. We'd give up our Saturdays and Sundays to come in, and everybody that I knew back in those days had weekend jobs and worked Thursday evenings and so forth to make ends meet as students.
And we have to be fair. Like, I know, like, for example, at the moment, I'm getting, a higher volume of students that are asking for considerations for attending classes at certain times because they're working full time. So many students are now working 40 hours a week. They're working jobs. Now, that could be argued two ways. Some of them, yeah, they have to do it. They have to do it. There's no other option. To dedicate 5 years of study, there's no other option. Some of it, yeah, certainly it's self-inflicted. I mean, they're walking in with, iPhone 16s and Mercedes-Benz in the car park. Some of it is probably self-inflicted. We had that flexibility. We had the opportunity to do those sorts of things, to be able to come on weekends. Some of them, I have to empathize with them. Their hands are tied. They can't do it. They're not able to do it. And some of them are disinterested. It is what it is,
Yeah, that, like I said, there's personal responsibility there that always comes back to it.
And just so that any listeners seem to, kind of indicate, I wonder who the presenter was that came last week. This person was, kind of presenting on functional counter strain.
Right.
There's, indirect technique, something that most people get very, very excited about, and less than 10% of the student cohort is able to attend. I mean, it kind of just indicates to you that, there's a few things.
Given the, I guess, the changing nature of what students go through within their course, do you think that we need to relook at, and this is not just osteopathy, but education in general, but I guess we're a little bit different in the healthscape, especially with the hands-on aspect of what we do. Do you think that we need to relook at how we deliver the course material to make it a lot more streamlined, a lot more user-friendly, time-friendly? I mean, we can just look at now the post-COVID mentality of the workforce, working from home, everything's online, everything's on Zoom, everything's on, do you think education has caught up to that? Do you think have we looked at new technology in terms of delivering education? I mean, I don't know what access there is to wet labs anymore, from what I hear. Nobody kind of uses wet labs anymore, which is a shame. So do we have an avenue where we could take anatomy and make that online? Can we take physiology and make that online? Can we take a lot of things that we might have to come into university for and turn that into really interactive online education, where then we can free up the time for students to be able to actually either earn some money or go to an internship or come to a weekend seminar? Do you think there's that aspect there?
It's already happening. It's already happening. I mean, Victoria is, fondly known as the education state. It's probably the largest export, if not second largest export that we do. But the tertiary education sector right across Australia, I think, is about to undergo some very, very significant reform and significant change. As tertiary institutions, we've relied upon very significantly on the kind of desire of international students and those markets, and we've been over the last 2 decades really significantly kind of leveraging that and delivering very, very substantially to that market. The legislation is changing. They're now going to put some international caps in, if I'm not mistaken, that's been approved or is about to be approved. But they're putting caps on international students, which means that the tertiary education is, sector is about to undergo some very, very stringent and very, very significant reform. Firstly, I don't know if you know this, but we've got a population of 26, 27 million. There are 36 universities in Australia. Think about that. 36 universities for a group of 27 million people. Way too many. There are going to be some changes, I think, fundamentally that do think about, trying to streamline things. The other thing that's happening, and again, I spoke about this earlier, which is you've got highly trained individuals. They're highly trained in one individual thing. The idea, now we're going through this digital transformation and digital age, very similar to when we swapped over from the agricultural age to the industrial age. We're experiencing that right now. And this idea of dedicating your life to one career, one profession, it's long gone. So we're going to have to think about, and tertiary education is already starting to think about how do they make themselves relative to this new digital age market. There are ideas floating around of this is not happening in osteopathy, so I hope listeners don't freak out about this. But generally speaking, across higher education, they are already talking about a pick and mix degree almost. So you get in with a baseline degree or whatever it is in economics or whatever base it is, business, and you have a core group of courses that you do, and then you have a very large selection of pick and mix. And so the individual then that graduates, you're thinking about them as their own brand and their own entity, as opposed to a big cohort. I think as osteopathy, bringing it back to osteopathy, we're going to have to start to think about these sorts of things. And at RMIT in particular, I'm sort of proud to say that between myself and my colleagues, we're really thinking about this going forward. I don't think we can continue potentially. I mean, I'm saying this as potential. We are putting question marks on things. We're going to have to think about what does that look like for the future. How do we expand and bring in other health professionals, for example, nurses who are done with nursing? How do we retrain them? You can't have a nurse who's a middle-aged person has the responsibilities that they do to come and study for 5 years. It's just not going to be possible going forward on campus 25, 27 hours a week. I mean, I think about that and I think to myself, no, I wouldn't do it. So we're really going to have to think about innovating if we want to thrive, if we want to, and I talk about these two things very separately. Surviving is one thing, but survival is horrible. We need to thrive. We need to move forward. We need to innovate. We need to be thinking about these sorts of things going forward, about how we educate our osteopaths in a way that's obviously still rings home and still rings true to our identity and our uniqueness and that, kind of core that we have. But at the same time, how do we then, allow ourselves to compete in a changing and an evolving market?
Right. Okay. So I'll continue on that note. But before I do that, you just mentioned about, holding on to some of our uniqueness and our identity. So I've asked a few other people this question. So I'll ask it to you as, what is osteopathy?
For me, look, again, I think, I'll give you the cliche answer of being both a science and an art. I think the art tends to be kind of individual in how people execute it. But I think if I would really put it down to, I do strongly believe, this is just my personal opinion, I think it's our rationale, our thought process, and our clinical reasoning. Hands-on technique can be replicated by anybody. And we can see ourselves that there are some other manual therapists and musculoskeletal health professions that are usurping the techniques that we would once believe to be wholeheartedly osteopathy. So technique doesn't really uniquely identify us. I think it's our thought process. I think it's our rationale. It's our
So
clinical reasoning and our clinical understanding and how we approach musculoskeletal health and musculoskeletal conditions. I think that's what really sets us apart.
can you define that though? Like, can you define what our reasoning is? I mean, we say that a lot of people say that it's our thought process, but then when you get 10 osteopaths in a room, they can't really define what the thought process is. Like, what is it that you
It's the
think that
physical
is?
implementation and again, thinking about those principles and how we consider those in our patient approach. Yeah, how do we implement those ideas and those philosophies, in a way that obviously, has to be attenuated to and amended with and
Mm,
informed by evidence that we have right now. I think it's really those philosophies and those ideas and that implementation of that is I think fundamental. This idea of even, structure and function and the whole body being a self-regulating, self-healing. Like, I mean, those are still very, very important principles. I
mm.
think it's that approach and that clinical ideas and those clinical reasonings in our approach, then utilizing what we know fundamentally as our basis, me personally, our evidence informed and evidence based science that we do have, using that as a platform to then move into other things that we already know and think about.
Okay, you mentioned also about the musculoskeletal medicine side of things. There's been some, I don't want to say pushback or talk, but a lot of osteopaths don't like to kind of pigeonhole us as just musculoskeletal. I had John Smart on the podcast a little while ago. John graduated from UWS like me and you did, and he was there. I think he was one of the first to graduate through, and he doesn't like the fact that we're being marketed as musculoskeletal therapists. He thinks there's a lot more to osteopathy than that, in terms of the neuro-emotional as well as the, I guess, systemic applications of osteopathy in things like any systemic disease, inflammation, looking at diet, looking at psychology, and so forth. Do you think that osteopathy is best served to stick to musculoskeletal medicine, or do you think that we have an opportunity to, I guess, do what we've traditionally done?
I mean, look, there's always opportunities. I don't think we should be restricting ourselves in particular, but I mean, at the end of the day, also we need to look at, we need to be able to peg ourselves somewhere as a starting point. And at the end of the day, also our training is in that space. It's always been in that physical space when we're talking about structure and function, and we're talking about these sorts of things. I think I don't want to put limitations. I don't think it's right to put limitations of what we are and what we can do. But I think that, ultimately, what I would like to pitch as ourselves as, and I have to credit some of this with a former colleague of mine who I still continue to work with in some capacity, Lee Muddle. We came up with this idea of being, primary healthcare practitioners with osteopathy skills. That's really what we are, and that gives the opportunity to be over and beyond and really encompass everything osteopathy really has to offer. So that's really the space that I want to be thinking of us in from that perspective.
Okay. Given your particular position at RMIT, has there ever been any kind of attempt or desire or any kind of willingness to maybe tap people on the shoulder and headhunt people to teach at RMIT versus just taking applications? Like, as you as the head of the program, as you might look and go, look at this person. They've been doing this for X amount of years. They're really great at it. They've shown competency. They have a passion for osteopathy. They need to be teaching this technique, or they need to be teaching first year or third year or whatever year you want to talk about. Can you go and tap them on the shoulder and say, hey, I'm running the program. You need to be with us because we think you're fantastic. Is that something that happens in tertiary education in your particular experience?
Look, we definitely have the capacity to be able to do that. But I think that, fundamentally, academia is hard. It's a hard place. Being at a university is a very, very difficult organization to be working with. Between 2015, 2016 till about 2020, we used to put recruitment ads almost on a yearly basis, sometimes twice a year. The number of bright, starry-eyed, beautiful practitioners who are successful in practice who would like to come back to give to the profession that I've seen come into our department and then sadly exit within 6 to 8 months, far too many to count on, even on two hands. And fundamentally, because being an academic and the requirements of being an academic tend to go substantially beyond your ability to be able to kind of, uh, um, teach and just think about technique from one perspective.
So
There's the
how do we make that easier for them?
Well, how do we make that easy? I mean, I don't think easy is the right word. I think
Easier,
it's
or maybe less distasteful.
Well, I mean, it's the machine, it's the game. It's there's very little that we can do about it. I mean, fundamentally, we have to be, as educators, we have to be, thinking about our students, and students have requirements. There are processes, there are systems, there are things in place that protect, for example, the student experience and what that's like, and that has a numerous things that go along with it. There's administration that goes along with it. There's other aspects to being an academic. It's not as straightforward. Like I say, it's very different to what it was 20 years ago.
Mm.
We had the opportunity for at UWS to tap those individuals and say, hey, come and do a seminar here, or come and do this, or come and do that. The demands and the requirements now have substantially changed. It's no longer like that. And again, like I've said to you, I've seen such amazing practitioners who, within 6 to 8 months, it just becomes very, very overwhelming because the teaching aspect of it, becomes this much of their role, and the other aspects of it start to dominate. Even thinking about learning management systems and putting lecture notes and putting tutorials and putting lectures and putting interactive activities. These are the demands of a modern, tertiary education institution. Every person has to step up to that play. And if you find yourself that you've got this passion for this technique, or for this passion for this approach, or this teaching, or teaching this thing, you'll find that that gets drowned out pretty quickly, and you're overwhelmed with other things that you have to do to be able to maintain your sort of role within that institution.
So what you're saying though is that primarily education is shifting more towards people who are academically tilted, that have a leaning towards the processes and systems of academia versus the actual application of the. I mean,
No, I don't think that's what I'm saying. I think that's not what I'm saying. I'm just saying that the skills that are required have to be able to be matched in other areas.
well, you
We
said
used
that. Sorry, but you said the particular aspect of teaching is only that much. Yeah, the technique is very little, but then there's a lot that comes along with it in terms of systems and procedures and operations and being able to
Yeah,
put
but
up
I mean,
lecture notes and all that kind of stuff.
but
Is
if the
that is
person
Yeah.
if the person comes in with a high level of skill set of a teaching of a particular technique or approach or whatever it is, and it's at this level, they have
Mm,
to upskill themselves in other areas as well to be able
mm,
to perform. You know what I mean? So it's not necessarily taking away from what their base is and what their skill set is. They
mm.
have to be able to perform in other areas in other ways as well. And
Yeah.
so they find that the sustainability of that and those skills become very, very challenging.
Mm.
That's what I'm saying.
Right, but does the actual profession then orient itself towards people who are competent in the things that you just mentioned, not rather at the expense of, but when you interview somebody, do you make sure that they need to be competent at those things that I guess are required of the teaching experience, not just the actual technique application? Like
We
when you.
fundamentally recruit, obviously majority of our recruits are clinicians.
Mm,
There are very small handful, even in our department currently, as I said, of 7 or 8. There's only a small handful of us, probably about 2 or 3, that are
mm,
have PhDs and are doing research, etc. The other majority, are not sort of at the moment, in that space, but are working towards. But when we interview, we get applications from clinicians. As I said to you, they come in as clinicians, they come in with this expertise, but they have to upskill themselves in other ways. And that can be challenging because you're stepping into a completely different zone. And again, I'm reinforcing the point that all of our staff members, every single one of us, we're registered osteopaths, we practice as osteopaths, and every single person in the program that teaches osteopathy skills are osteopaths.
mm. What particular challenges do you see ahead of you as a not you personally, just you personally. I mean, we'll talk about that if you want. But in terms of the actual course, the education there, the osteopathy course at RMIT, what particular challenges do you see coming up in the next 5 years for that particular course? Like, where do you see some of the things that you need to look at to kind of make sure that that course has some steady footing?
I mean, look, at the end of the day, I think, as I said earlier, that I think the tertiary education sector across the board is about to undergo some very serious reform. Every universities are incredibly complex and complicated organizations, and fundamentally, in order for be able to any institution, any organization, for it to be able to conduct its core business, it needs to be viable. It needs to be able to be thinking about, and I'm not talking about only financial viability. There are other resource viability. There's all sorts of viability that comes into a thing. I think that because there's going to be some changes in the higher education sector across the board, as of the osteopathy department, the thing that we're going to have to be thinking about is how we start to make ourselves and think about ourselves in that new and innovative way, and implementing those suggestions and ideas and moving forward. Whether that's, whether it's got to do with our clinical training that we do, the supervisors, the academic workforce, whatever we have, we need to be able to conform to what I think is going to be quite a substantial change over the next 5 to 10 years.
Mm.
Um,
Yeah, one of the questions that I wanted to discuss earlier, and I'd forgotten about it, but it's just popped back in, so I want to circle back to it. Um, one of the things that I get feedback on from not just the business owners, but even from graduates, and especially people who are, say, moving on from that early career phase into looking at either having their own practice or even just going on their own and being a sole trader, is that there's very little business education. And this is not just osteopathy. I think if you're learning how to be a chef, or if you're learning how to be, anything, a teacher in the private space, you don't get, no one teaches you how to look at a balance sheet. No one teaches you how to look at a profit and loss statement. Nobody teaches you how to, understand the basics of cash flow and assets and liabilities and so forth. And so you get out to this world of not just osteopathy, but business, and you're very raw and green. And that can be quite overwhelming, because I think that really comes back to your livelihood, the amount of money that you make and what you're bringing in and what your expenses are. If you're an employee, it doesn't really matter to you as much. And I guess most academics would be employees of education. And so is there any kind of talk within your particular institution, especially through the osteopathy program, in making sure that there's some more business education for people who are exiting and graduating that program? Has that ever been brought up?
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places: the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy, and back to the show.
Yeah, absolutely. I mean, in our new program, we actually have one course that we're doing. It's a unit, we call units or subjects courses at RMIT, that's specifically looking at business and entrepreneurship in health. So this is a full 12 credit point course taken over a semester, where you're learning skills in, business development, and in particular that entrepreneurship aspect of it. Thinking about modern solutions for, health issues, or strategies for problems that we have within the sector. So, we are substantially, and well, I wouldn't say substantially, but there is a conversation around that, and there are some solutions for that. At the end of the day, also, I think that some of these things, the demands on you know, what we're required from an accreditation perspective and what we have to teach. And again, it goes back to this idea, like I said, I think the fundamental idea is the health market is changing. The graduating landscape is changing. You know, in our program, we have to educate our students on, for example, cultural safety and First Nations health. That's something that wasn't there in the curriculum before, but now every single healthcare profession has to have some element of it in there. These ideas about telehealth and telemedicine, AI, digital health, like these are all new concepts that are demanded from a modern healthcare profession, but were not there previously. So there are always competing, sort of spaces, competing ideas. And, again, like I say, we're focused on our core business. And I think our core business is graduating osteopaths that predominantly go into private osteopathy practices. And we've got this solution or this idea that we could run a course that thinks about modern healthcare solutions from a business perspective, streamlining healthcare practices, whatever the ideas are. I mean, the task that we're setting for students is actually quite interesting. It's probably beyond the scope of our conversation here. But we are thinking about these sorts of things and coming up with solutions for it. But at the same time, I have to make it clear that the demands that we have are quite substantial, and the curriculum is already very, very jam packed. We'd have to keep students for 7 or 8 years if we
Yeah.
wanted to substantially kind of elaborate on these. And
Yeah.
again, we know from our research and from data that it's only a handful of graduates that are actually choosing that pathway. Significant number of graduates are choosing to go into mentorship roles, in particular, mentoring roles or being mentees, and are more considering co-locating with their mentor in the same clinic or in the same thing. That's already still pretty much widespread for a significant number of our graduates.
Yeah. Look, it's definitely, I think business basics is important, but more than that, like you're right, there are competing elements to a tertiary education course, especially osteopathy that intends to keep osteopathy in it. You don't want to, obviously, the more you put in, something's got to give. And so I understand that perspective. Uh, and so this leads me on to my next question in that we discussed earlier about I guess, the lack of interest in the current student to actually take on any extracurricular, I guess, education, or if you bringing in outside lecturers to do a weekend seminar or of that thing, or of that kind of thing, hasn't really shown a lot of interest. What advice would you give to I guess a fourth or fifth year student or even an early new graduate in terms of taking up a lot of the courses that are available now? Because there's been a big, I guess, mushrooming of courses out there for osteopaths in different areas of expertise. So you can do a lot of, functional biodynamic work. You can do a lot of structural work out there. There's seminars on craniodental. There's seminars on literally everything, pelvic health, and there's so much out there now, and I think that's great. What advice would you give? Would you advise students and early graduates to go and sink their teeth into that stuff, and also, yeah, would you advise them to do all that? And what would be the emphasis? Would you place a big emphasis on that for them to continue to develop and learn post graduating from the university course?
I'm going to say something controversial, which probably most people won't like. I think that to your latter point of continuing development, 100%. I voice that message very, very loudly and make it very, very clear that continual development, and this is something that we need to structure within our profession itself. It's lacking. We don't have this. We've got graduates that come out, and the expectation is that they hit the ground running. Yes, they should be hitting the ground running. But again, the career sustainability, where's the growth coming? How is it coming? How is that occurring? Right? We need to be thinking about this as profession leaders and be thinking about it from that perspective. So, to your latter point of development, 100%. The controversial part here is I actually advise the students of opposites, which is do not engage for the moment in those further courses, particularly when it comes to courses that they think that they're going to benefit from to um, kind of modify very significantly their treatment approaches or anything of that nature, at least for the first 2 to 3 years. It is
For the
really
first
critical
2 or 3 years post graduation,
post
or
graduation. Yep.
right?
I think very strongly, and again, like I said, I've prefaced this by saying that it is controversial. I think it's just noise. It's white noise. They won't benefit from it very, very significantly. And some of these kids are laying out substantial amounts of money. I mean, I am, I'm into chronic pain research. I did my PhD in pain. I love that pain science content, and I contribute to it very, very significantly. But the number of students that I now see going off and doing those $50,000 master courses in chronic pain, I mean, yeah, they might get an additional amount that they're going to get apply knowledge to their practice, but they're not going to significantly benefit from that if they haven't honed skills on basic communication with patients. You know, if chronic pain management fundamentally depends on communicating with your patient, educating them about pain sciences, motivational interviewing, all of these skills that they apply, it fundamentally requires you to be a good communicator. And if you haven't worked on those skills a year, 2 years, 3 years after graduating, then I'm afraid you're not going to very significantly benefit from that. So I always advise students for the first 2 to 3 years, don't do anything. And not say don't do anything, but don't substantially go off in a one direction and do things that are sounding incredibly fascinating and fundamentally changing what your approach and thing is, because you've got the right skills as a graduate early on. I mean, the kids that are graduating, they're going to be the most evidence informed as possible. They've got the basic skill sets. It's important to be able to perfect those before they start adding to their repertoire. I also, unfortunately, and again, this is going to be controversial, but I have to let my feelings be known. I also do get rather, kind of, I mean, I don't say irritated is the right word because it's not my place to be irritated, but I do think that it's not beneficial for fourth year and fifth year students to be doing CPD courses. They're just not going to be able to benefit from it at a level where if they were to do it further down the track. And my own personal experiences teach me, after doing a couple of courses of cranial, literally the first year or second year that I graduated, first time that I worked on a baby, kind of doing that work, out of a 30-minute appointment, we spent 20 minutes or 23 minutes getting their nappy changed because the baby had done a poo on the table. Like I had done all of these courses to be able to try and benefit in that way, but I didn't know how to actually do the most basic things. So I think that the advice should be to stay connected, absolutely stay connected, develop good networks, start to execute your skills and start to become a practitioner in a whole sense of the word. Focus on that first. Then after a couple of years, then you can decide, okay, I know that the gaps that I have are X, Y, and Z, and you're going to go in a targeted way and a targeted fashion to be able to plug those gaps and fill those knowledge gaps or those practice gaps. That is far more effective than sinking yourself into another $50,000 master program.
Right. So I guess though, if people want to, I mean, talking about a $50,000 master program, I understand that bit. I mean, they would be sinking themselves more into debt, so that doesn't make sense. But if somebody has been out for a year and feels like that they need to have a refresher on their HVLA technique,
Oh
or
yeah,
have a
absolutely. I have nothing against that. I have
or if they
nothing.
want to
No,
go do one of you know a course with Rudy Gerhardt on understanding concussion, because they're starting to see concussion patients in the clinic. If they want to go do a HVLA course with John Marshall, if they want to do basics, we're talking basic stuff here.
absolutely.
Is that what you're talking about? Or are you talking
No,
about no?
no. I'm talking about more advanced things. I'm talking so those refreshers, those other courses, those are the things that are skills and things that are familiar to them. Wholeheartedly, I don't have a problem with that. I think I encourage that because there is a time and a place, and you will definitely benefit from those things that are familiar to you. I think fourth and fifth years in those courses, again, quite questionable. Why do it if you're all learning it and you've got access to clinicians and so forth who do it on a daily basis. So again, that's a little bit. But as a 12-month new graduate, 24-month new graduate, absolutely. Go and do those HVLA courses, go do those other courses, go do some other things, not a problem. But the big kind of substantial fundamental changes to your approach and cornering yourselves into only being, say, for example, a cranial a
Mm.
practitioner, or only focusing on counter strain, a practitioner, or only focusing on a chronic pain practitioner. I think some of these skills are probably more beneficial at a stage where you've mastered or at least
Mm.
become a little bit more competent at the core craft. Because
Yeah.
regardless of what you do, even if I go and become, become a master at functional counter strain, I go to America and I do all of those courses and I come back. If I can't communicate with my patients, if I can't, figure out prognosis, if I can't plan a treatment plan, what good are those skills to me? Are they going to benefit me substantially? Probably not.
Mm.
So those are things that are best done at a latter stage. And again, that's just my personal opinion.
Yeah, no, given that clarification, as I would tend to agree with you. I think that especially a lot of the courses that require, I guess, I don't like to use the word advanced because I don't think they're advanced. I think osteopathy is osteopathy. But a lot of the courses that maybe have a requirement that you have had to see at least a certain amount of patients in your short span of being a practitioner, you can build on the skill set that you have, and that you'll actually get more out of those courses later on. Like even doing, I spoke to George Stillian on the podcast not long ago, and George is a very competent biodynamic and cranial practitioner, and he said the same thing. He said that usually the best practitioners that end up doing that stuff are very good structural practitioners first. They've done a whole bunch of years doing that, and then they've gone on and they've filled up some gaps and they've gone and practiced and seen a whole bunch of volume of patients, and then 10 years down the track they've kind of gone on and expanded their skill set. And that's coming from somebody who runs these courses. And that was his. So given that you clarified that point, because I just want to be clear that you're not talking about a 1 day 6 hour little refresher or learning about, I guess, how to look at the upper limb and look at the strain patterns and the different problems that you see in the upper limb or the lower limb, and applying what you already know, what you've already learned,
Yeah.
in a very osteopathic sense. You're not talking about that. You're talking about, something that's a bit grander, that's a bit bigger, that requires lots of investment, that requires that you maybe have some more skills at your disposal first.
Yeah, yeah,
Would that be
absolutely. Yeah,
correct?
absolutely. So yeah, just to be clear
Yeah.
again, those refresher 6 hours, 1 day courses where you're, kind of getting another unique perspective on application of something that
Mm,
you've already been exposed to.
mm,
We have lots of students that go off and do dry needling techniques, for
mm,
example,
mm,
and we
mm,
do a little bit of demonstration of dry needling in the program already. So if they go and expand upon that and go do that,
mm,
sure, why not? That's not a thing. But I'm talking about, very large amounts of investment,
mm,
taking you off in a very, very different direction, not quite honing, those or mastering, I don't know necessarily the right word, but mastering those basic skills to begin with, because those
mm.
beginning skills is exactly what you need regardless of where you go. And some of
Yeah.
those skills are undervalued, being a good communicator, being able to speak to your patient, be able to explain things in layman's terms, being able to, take very complex issues and problems and to be able to explain that in a way. I mean, the evidence about around that thing is undeniable as to what it can do for patient prognosis and patient, kind of outcomes. So, getting graduates to really think about how they develop their flavor and develop their own skills in that area, I think they should probably focus on that before they go off and do more grandioso things.
Mm. I want to ask you a bit more about what you mentioned earlier, the concept that you, I guess, credit yourself and also Lee Muddle for. I mean, I'm not sure if it's a new concept, but I guess you guys have talked about it. That osteopaths or the role of the osteopathic practitioner is to be a primary healthcare practitioner with osteopathic skills. Is that correct?
That is correct.
Right.
Yes. Yeah. Yeah.
If I say to you that we flip that on its head, and we say that the practitioner is an osteopath who is a primary care practitioner. That's different than what you were talking about. Can you comment on that?
Well, I mean, I think that if we flip it the way you've said it, I mean, obviously we want to be able to, function also, beyond just manual therapy, right? Manual therapy is a component of what we do, is a very large component of what we do, but there's other aspects of it that we have to also be able to offer up. Broadening that scope, broadening that role, being the facilitator, for example, of a patient's healthcare and referring to individuals, being part of a healthcare team, for example. These are all skills that are, again, required, absolutely fundamentally expected of new graduates that are going out there and are working in the health space that they currently are. So, I think that that course, and this is the message I really want to try and get across. There tends to be lots of grievances from individuals, and I get these grievances, and I think you've alluded to those as well, or mentioned very explicitly that you get those grievances about the loss of manual therapy, hands-on skills, and those technical skills. I want to make it very, very clear that there shouldn't be any grievances because there is no change or no downshift as far as that's concerned, or culling or anything of that nature. It's the other skills that we're really trying to uplift at the same time. And again, we looked at, there was a paper that we published in 2024, and there were a group of us on there, including Sandra Grace, who was the first author, professor from Southern Cross University, Roger Engel, Lee Muddle, Chanel Mastronado, Brett Vaughan, Michael Fleischman, and myself. And we looked at enablers and barriers for, telehealth and osteopathy during COVID. And we definitely found that there were certain individuals who were so linked to that identity of hands-on manual therapy that they weren't able to do anything during COVID lockdowns, and their businesses were actually significantly harmed during that time. Whereas we found other practitioners who were able to think about themselves and their role slightly beyond that and were not attached to this, kind of identity of only if I can't touch people, I can't help them. If they thought beyond that, the stories, the analogies, and the success that they've seen in their businesses in COVID, during COVID, and beyond are significantly substantial. And these are the sorts of things I certainly believe that we need to be leveraging a lot more because it broadens the access to osteopathy. Isn't that what we want? Isn't that what we want to
Yeah,
do for a thriving profession?
yeah. I
Why
think
are
I
we
think.
keeping it to ourselves? Why are we keeping it in a box? We need to share it. And
Mm,
if there are ways of being able to share it that are innovative, that are new, this particular practitioner that I'm talking about, I mean, he's into barefoot running and training.
mm,
His practice was only drawing individuals within his local community. He now consults people literally right across Australia. What a
mm.
fascinating way to be able to be an osteopath, I think.
Yeah, no, I think you're right. The grievances that I'm hearing, to be honest with you, is not so much about the lack of hands-on or the lack of technique. The grievances that I hear about actually have more to do with the rationale. That there's been a movement away, because when you say that all primary healthcare practitioners are moving in the same direction as physiotherapists, so there won't be anything. And I look, I had a chat with a very experienced osteopath, and you mentioned his name as part of a committee that you have, right? And you could go back and listen to that, and you'll know his name. He's probably the most experienced that you talked about, and he said outright to me that at one point we won't have an osteopath, a physio, a chiro will all just be the one kind of identity, and that there's nothing wrong with that because ultimately it's the patient that needs to win, and we shouldn't really be attached to our particular rationale or thought process. So, there is aspects of that I agree with, that the patient always needs to win. That's what we're here for, to be patient centric. But the patient is also I guess, the consumer. And if the consumer is asking to see an osteopath, the unique opportunity that presents itself in front of us is that we need to be osteopaths. And if we start to diverge our thought process, our rationale, our philosophy, the very thing, as that you mentioned, was what defines us, that's when we lose that, and we stop giving that to the consumer. Like it's better that the consumer has options. We don't want a generic practitioner. We want the consumer
Understand it.
to have options. And so
100%.
the grievances that I get is not so much that there's a lack of, because you can go to there's lots out there. You can go and brush up your technique, and even if you speak to, I would love to have really slick graduates coming out and their techniques on point. That would be fantastic. But that may not happen. That's not a problem. There's plenty out there. They can go and learn. They can have mentors. They can do all that stuff. The rationale is the grievances that I hear is more about the thought process, the rationale, and the problems come is when you do have people in education that don't believe inherently in what you said earlier about the uniqueness of osteopathy being in its rationale. Then that becomes a problem, because I think that graduates don't then have that spark that they are different, that they have a unique position. When I don't think they have that, there's not much they can build on. And so that I just want to clarify that, because you said the grievances was about technique. It's not. It's more about the actual thought process and rationale. And you're right. If that thought process is there, we can move into telehealth, because it's a thought process. It's not a technique. I can sit there and have it. I mean, we just had it. We've been sitting here talking for a couple of hours, and people can listen to this and learn from it and take something away about scoliosis or treatment of whatever. And this is not hands-on. It's just me and you having a conversation. And so there are elements of that, and I agree with you that we need to encourage that. But I want to just make it clear that the key to being able to be a telehealth osteopath is the rationale and the thought process and the principles. It's not the hands-on stuff. That's great. It's lovely. We want to keep that, but that's not the key to it. The key is how you think. And we don't want to lose that in our tertiary education.
100%. Yeah. You've summarized it really, really well. And that's exactly what we're saying. I mean, I think you and I are on the same page as far as that's concerned. We both are agreeing to some extent. Again, all of this, I said to earlier that osteopathy is both a science and an art, and how that art gets implemented, there are going to be a variety of opinions. One thing that Ray used to say, bless him, he used to say that, if you get 10 osteopaths in a room, you'll get 20 different opinions. So if we're agreeing as a profession, as a group of individuals who are suggesting that, yes, that our uniqueness lies in our thought process and how we approach patient problems, that's the uniqueness that's there. And we need to really offer forward the threat of attaching ourselves and our identity to only techniques. It can be usurped by everybody. So techniques that are applied without the thought, without the rationale, without the clinical reasoning, I think both of us can agree those are not osteopaths. If you don't have the clinical rationale and don't have the thought process, if you're not applying those ideas in that way, and you're just applying technique, anyone can do that. Allied health assistants can do that if they're trained to be able to do it. So, really, yeah.
Sorry,
So it's really about that strong kind of identity that we have, and we can do it in many ways, including in private practice with hands-on manual therapy. Yes, and we can do that, and we do that, and we do that really, really well.
Yeah, and it's that fourth principle that was stated, where an osteopath applies rational treatment based on the first three principles. I mean, that fourth principle is there for a particular reason. And whether you have a registration paper that's saying that you're a registered osteopath, whether you went through you got a certificate from a tertiary education saying you're an osteopath, if you're not following that fourth principle of actually applying rational treatment based on those three principles, I'm sorry, you're not an osteopath. Like that's my opinion, and that's the controversial part that I'm going to say today. And I guess I would hope that the educators are applying, just like you said, that a technique taught without the rationale, or a technique applied, to a patient without the rationale, isn't really as effective. A technique that's taught in the university setting without the rationale and the principles behind it isn't taught as well as a technique that can be taught. I mean, you can get a chiropractor to teach HVLA to osteopaths, right? But it's not going to be the same as an osteopath who's teaching it with the rationale of an osteopath. And so I mean, this is just my hope that that's happening at university institutions. I want to give you I want to give you a last question because we've been talking for a while. It's been a fun talk. I'm enjoying this. We could go on for a while, but what are some of the challenges that you see ahead of us as a profession in the next, say, 10 years? I mean, moving just not just tertiary education, but just challenges as a profession. Um, what do you think? What do you think the challenges lie ahead of us as?
So look, we did a substantial amount of work as part of that project, which was a grant that myself and Lee received through Osteopathy Australia. It's called a strategic plan for osteopathy profession to 2030, and so as part of that project, it ran over 2 years, maybe even 2.5 years. We had a steering committee that we had, practitioners, educators, variety of experience, variety of breadth, all the way down to new graduates. We also had individuals that were equally represented from different states, or at least they had experience working in states. So we had one person who had spent 3 or 4 years in WA and was speaking potentially on behalf of WA. And we came up with a series of recommendations. There were 9 recommendations that we came up with. So this is thinking forward to the 2030. And I would highly encourage everyone to go off and read that who's interested in that. It's available through Osteopathy Australia website. Just look for it. And the recommendations that we come, so we did a SWOT analysis and we did an environmental scan. And based upon that SWOT analysis and that environmental scan, we came up with a series of recommendations. So when we thought about funding, for example, what are our threats there? What are our opportunities there? Policy, what is our threat and recommendation? Oh, sorry, and our opportunities there. Regulation, from APRA, etc. So, the recommendations that we came up with were, thinking about diverse careers. So obviously not only having osteopaths in private osteopathic practice, but adding to that list of careers and thinking about training in that perspective. We had a recommendation of connecting further with technology, so developing kind of telehealth capabilities, for example. I mean, how amazing, like we've got osteopaths, say, for example, even in Sydney, right? I mean, I'm aware of the situation there where, there are still some suburbs that don't even have a single osteopath within a 10-kilometer radius. In Melbourne, it's, some suburbs on a quiet street, you can find 2 or 3. But imagine if you were to be able to expand that beyond into rural, remote areas. Like it has a really, really strong place and a very, very powerful place to play, and a role to play. So that's one of the other
So,
recommendations.
what was that recommendation as? Like, as in, like, how do you
Well,
expand
so
osteopaths into those areas?
Well, so it's basically, kind of, providing the students and graduates with a skill set on how to be able to conduct consultations, how to be able to use telehealth within their consultations, and thinking about things that they can do that don't necessarily require, or periodically getting the patient to come into your clinic physically, but then also doing this remote aspect of it as well. So, giving them exposure to that. And again, like I said, we published a paper in 2024 in IJOM looking at barriers and enablers, and that's something again I think I would recommend listeners to read. We had something along with another recommendation we had was about engaging with the wider profession, having a primary care focus, developing new professionals, so thinking about industry mentorships, again getting everyone engaged and being able to pick up our new graduates and being able to step them through different stages of career, and having an
As
outcome.
sorry to cut you off there. Does RMIT still run internships?
We put a pause on it in 2024 due to the variability in student experience. We're bringing it back in 2025. So we are
Right.
bringing back the internship model where students are able to go out to individual clinical practices. There are some constraints around that and certain things that we want to put as guardrails,
Mm.
because, again, the experience was highly varied. And we did have the odd occasion of practitioners telling our fifth-year students that they should crumple their RMIT degree and throw it in the bin, which is not
Okay.
great. So in 2025 we are bringing it back.
Okay.
So those internships are coming back
And
on our
are
table.
they going to be open to interstate practices or
Yeah.
just Melbourne-based practices?
So we're hosting a focus group, shortly, to think about that and consider that. And there is definitely an interstate representative within that. There are logistical kind of issues
Mm.
around that. About shuffling a student interstate. who looks after their accommodation, who looks after their food, who looks after their
mm.
travel, how do they continue? So, there's a number of kind of challenges with that, but we're open to suggestions, and we're certainly looking at opportunities to be able to broaden it in the next few years.